This topic always gets me thinking, how do we actually put a number on something as, well, personal as being sick or healthy? Today, we're really diving into the science behind measuring these health state preferences. We've got some great research to guide us. Our mission really is to figure out how we quantify something that feels unquantifiable and see what that tells us.
It's a really fascinating area. What we're doing fundamentally is applying ideas from psychometrics, which itself grew out of psychophysics. That's the study of how we judge physical things, like how bright a light is or how loud a sound.
Okay, so taking that physical measurement idea.
Exactly. But applying it to abstract concepts like health states. The key thing is we're trying to scale the health conditions themselves, not the people doing the judging. And we use different levels of measurement for this. There's ordinal, which is just ranking this is better than that.
Simple enough.
Then interval, where the distance between points matters. Like the difference between a 7 and an 8 health state is the same as between a 2 and a 3.
Got it. And the last one.
Ratio, that's the gold standard, really. It has a true 0 point, so you can say one state is genuinely twice as desirable as another. Think height or weight 0 means none.
Right. So with those measurement levels in mind, how do researchers actually, well, do it? What are the methods?
There are about 6 main ways they tackle this. Let's maybe start with a couple of the more straightforward ones.
Sounds good.
Okay. First up is category ratings. You might also hear it called the rating scale. It's usually the simplest. Imagine a line, maybe 0 to 100, or just categories like 1 to 10, anchored by perfect health and death. You just place different health states somewhere on that line.
So like a thermometer for health states.
Sort of, yeah. And it's great for big studies because it's easy to administer and often gives you pretty solid interval scale values.
Okay, easy and useful for big groups. But what if you need that ratio scale to say something is twice as bad?
Ugh, that's where magnitude estimation comes in. This one's a bit more demanding. It asks you to think in ratios. If we assign, say, 10 to a particular state, how would you rate another state that feels 10 times more desirable? You'd say 100.
So it's directly asking for that multiplicative comparison.
Exactly. It aims for that ratio scale. But, crucially, research suggests its validity often hinges on how you define 0. Is it death? Or is it the complete absence of disease? That anchor point really matters.
Interesting how critical that definition is.
Yeah.
Okay, let's move on. You mentioned some methods are more decision-oriented.
Yes. These ask you to make hypothetical choices. Take the time trade-off or TTO. Here, you face a choice. Live for, say, 10 years in a specific impaired health state, or live for fewer years, maybe 8, but in perfect health.
So you're literally trading years of life for quality of life.
Precisely. It gets right to that core value judgment.
That's a tough one. And then there's the standard gamble, the classical method you said.
That's right. The standard gamble, or SG, it's rooted in economic utility theory. You're offered 2 alternatives. Option A is living in a certain chronic health state for sure. Option B is a gamble.
A gamble, like what?
A gamble where you have a probability, let's call it P, of being restored to perfect health, but also a probability, 1P, of immediate death. They often use tools like a probability wheel to help visualize the chances.
Wow, that sounds intense. Perfect health or immediate death.
It is, and what's fascinating is while it's theoretically appealing, people often struggle with it. Processing probabilities is hard, and we often see risk aversion. People might really dislike the chance of immediate death, even if it's small.
So they'd rather stick with a certain, even if not great, health state.
Exactly, which can lead to them assigning a higher value to that impaired state than they might with, say, the time trade-off. The TTO, while still asking for a trade-off, seems a bit easier for people to wrap their heads around than raw probabilities.
That really highlights the psychology involved.
Yeah.
Okay, were there other methods mentioned?
Yes, briefly. There's equivalence. This one asks things like, how many people in health state X would be equivalent, in some sense, to a certain number of people in health state Y? The paper notes, it can be quite complex, and honestly, sometimes perceived as insensitive or even offensive. Comparing lives like that, it's tricky territory.
I can definitely see that. Ethical minefield.
And finally, willingness to pay. This asks, quite directly, how much money you'd pay for a treatment or a cure. Seems straightforward, but it often gets low response rates. Plus, people might think differently about money versus risk, maybe focusing on function when thinking about cost, but pain when thinking about the gamble. Cognitive biases again.
So a whole range of tools, each with its own strengths and weaknesses. If we step back, how do they stack up overall? Are they reliable, valid?
Well, in terms of reliability, consistency, they generally do okay, although it's important to remember people's preferences aren't set in stone. They can change maybe during treatment or like the paper mentioned even during childbirth.
Right, context matters.
Right.
And validity, are they measuring what we think they're measuring?
That's the million-dollar question, isn't it? Validity is trickier. The methods often correlate people who rate state A higher than B on one scale tend to do so on others, but they don't always give the same numerical value because fundamentally they're asking you to do different mental tasks. Judging a magnitude is different from trading time, which is different from taking a gamble.
So different questions lead to slightly different answers, even about the same thing. Makes sense. So boiling this down, what are the practical takeaways for us thinking about this?
Okay, practical points. If you're doing a large study and need something efficient, category ratings are often your best bet, easy, generally valid interval data.
Got it. Simple and scalable.
If you really need that ratio scale, the ability to say twice as good, then magnitude estimation is the contender, but you have to be super careful about defining that 0 point.
Right. The anchor is key there.
And then, for situations like individual clinical decisions where you can really explain things and explore preferences in depth, the time trade-off or the standard gamble might be more suitable, provided, of course, you acknowledge and maybe even discuss the potential biases, like that risk aversion we talked about.
That's a really helpful summary. It all leads me back to a fundamental question, really. These methods try incredibly hard to bring objectivity to something that feels so personal, so subjective. Knowing how they work now, the different ways they ask the questions, the biases, it makes you wonder, doesn't it? How much do you think a year of healthy life is actually worth? What kind of gamble, what kind of trade-off would you truly accept for a cure? It's definitely something to ponder.